Good afternoon and welcome to our program today. I'm Tony Connor. I'm the Manager of Community Outreach for Pelham Medical Center. And on behalf of Pelham Medical Center, Gibbs Cancer Center and Research Institute, and Spartanburg Regional Healthcare Center, we're just so pleased that you could join us today. Before we get started, I want to tell you about some classes that we have coming up. On December 10th, Dr. David Bruschi will present a class on back care. The class is called We've Got Your Back, and he's a spine specialist, so we hope that you can join us for that class. We've decided that all of the classes through spring of 2021 will be virtual. So be on the lookout for a listing of classes that coming in the new year. We'd love for you to join us. But today we're thrilled to have Dr. Daniel Freed with us to do the presentation on technology with cancer treatment. Dr. Freed is the medical director for the Gibbs Cancer Center and Research Institute at Pelham, and also the program director for radiosurgery. Dr. Freed is nationally and internationally recognized for his research and for his cancer treatment. Dr. Freed holds a Bachelor of Arts degree in sociology, a master's in public health in biostatistics, a PhD in epidemiology, and a medical degree. We are so pleased to have such a learned and wonderful physician on our staff here at Gibbs Cancer Center. So we welcome him today. Dr. Freed I'm going to go ahead and turn this over to you now. Thank you so much for being with us. And if people do have questions, please type them in the chat box, and we'll have the questions at the end of the presentation. So welcome, Dr. Freed. We look forward to your presentation.
Thank you very much. I'm going to go ahead and take my mask off, but I do encourage all of you in this odd time we're living through to wear your masks. As was said, I'm a radiation oncologist. But before I was a radiation oncologist, actually, I was for a brief while an epidemiologist. Most people used to think that meant that I studied skin, but it turns out epidemiology really is something that is in the news a lot more right now with the infectious diseases that we're dealing with, particularly with this COVID-19 pandemic. Anyway, but today we're going to avoid that for just a few minutes. And we're going to talk about cancer, and we're going to talk about some technology in radiation oncology specifically. But before we do that, I'd like you to take a quick video tour with us of the new cancer center at Gibbs at Pelham. That's a beautiful center, and I think you'll really be impressed.
Welcome to Gibbs Cancer Center and Research Institute at Pelham. The 190,000 square foot expansion off Interstate 85 opened in March of 2020, thanks in part to the generous donors of the Spartanburg Regional Foundation. A climate-controlled connector bridge on the second level joins the Cancer Center to Pelham Medical Center for safe and comfortable patient transport. All of our programs are housed under one roof to make cancer care as seamless and convenient for patients as possible. If needed, patients will have access to free valet parking. They can pull their car right up to the building and not have to worry about parking. As you enter through the door, you are greeted with a beautiful interior. A staff member will greet you to answer any questions you might have and help you get to where you need to go. Off the main lobby, that special look boutique is available for our patients and will soon feature certified breast prosthesis fitting services. They offer wigs, specialty clothing, jewelry, and a variety of other items to make life more comfortable during and after treatment. Located in the same space as the retail shop, the pharmacy is now open. There are full-service pharmacy that can not only provide services for our oncology patients, but they are open to the public as well. They also offer over-the-counter medications in order to be a one-stop shop for our patients and their families. When you exit the pharmacy, the cafe is right around the corner. With seating for 40, this also gives patients and family members a place to relax and enjoy a snack or beverage. Around the corner from the cafe, you will find our chapel, created for patients and family members who need a few quiet moments for reflection and prayer. Inside, you will see the stunning stained glass windows. These were designed by a local artist who also created the chapel art across the road at Pelham Medical Center. Also located on the first floor is our full-service laboratory. 7 patient bays allow them to draw labs and run complex analyses in-house rather than sending labs to the hospital. This allows patients and physicians to get lab results much quicker. Back in our lobby, you will see our beautiful 7-story atrium. The stairway ascends to our second floor, where you will walk into the Cancer Library and Learning Center. Perry Patterson uses his expertise to help patients and their families learn about oncology disease states, treatments, and available services. The second floor also houses the Integrative Medicine program, which provides whole person care, including massage therapy, cooking demonstrations, and a survivorship clinic. Our Integrative Medicine department is where you will find the kitchen. Massage therapy and our oncology rehab area is down the hallway on this floor as well. Our oncology rehabilitation program helps patients regain range of motion after surgery. The program also includes speech-language therapy to help patients regain the ability to eat, drink, and speak if treatment has affected their ability to do so. Stacy Williams leads many cooking demonstrations to cancer patients in our nice demo kitchen. Currently, we are not offering these classes due to COVID. Massage therapy is a mind-body treatment that relieves pain, reduces stress, and promotes healing. Although not currently offered, this is one of the services provided in our Integrative Medicine program. On the 6th floor is the Gibbs Patient Center. There are 3 clinics which house medical oncology, GYN oncology, surgical oncology, and palliative medicine. Up on our 7th floor are the infusion services, which boast views of the mountains, airports, and lush greenery from surrounding forests. This floor significantly expands infusion services. The previous Pelham facility had 5 infusion bays. The expansion now has 40. 32 spaces are private infusion bays with recliners. The remaining 8 bays are private beds specifically designed for patients who are unable to sit up during infusions. Off the main lobby, the Marcia and Jimmy Gibbs Conference Center is a 120-seat auditorium for community events, lectures, and multidisciplinary planning conferences. Radiation oncology is a full-service department with a CT scanner, linear accelerator, and the CyberKnife system. This is a non-invasive alternative to surgery for the treatment of both cancerous and non-cancerous tumors. Around the side of the building, you'll see our garden area and fountain. As weather permits, patients and their families can sit here, relax, and enjoy the soothing scenery. None of this would be possible without the generous donors to the Spartanburg Regional Foundation. From all of us at Gibbs Cancer Center at Pelham, thank you.
Okay, well, I think we can all agree quite a beautiful building, and I think is going to offer our patients a tremendous amount as we get everything up and running there. Now, this gives you a little bit of a sense of where we started. So the Gibbs Cancer Center was started back in Spartanburg back in 1999, and over the course of the last 20 years, the number of patients that we have seen has expanded quite dramatically, and you can get a little bit of a sense of that here. Annually, we're treating over 2,100 patients, and over the course of that 20-year history have treated more than 35,000 patients. Oops. Now, the Gibbs Cancer Center has been recognized for a number of different things. Starting back in 2015, just to talk a little bit about the CyberKnife here, which we're going to talk about more in just a few minutes, we had the first in the country fully functioning M6, which is the newest version of CyberKnife, with kind of all the bells and whistles. Kind of a quick funny aside is that we actually were kind of in a race with Stanford University, which is actually the birthplace of the CyberKnife, to get this machine up and running. We had a really expert physicist who was able to get our machine up and going prior to when the Stanford physics team could. So it gave us the recognition of really being the first ones in the country to have this great piece of equipment available for our patients. Also in 2015, we introduced something called SpaceOar, which is a water-based gel that can be placed into the space between the prostate and the rectum for prostate cancer patients in order to help protect the rectum from injury due to radiation. Now, over the years, we've had a number of different recognitions from various cancer organizations, including American Society of Clinical Oncology, the Commission on Cancer, that have recognized the excellence of the Gibbs Cancer Center and Research Institute program. And in 2019, we were awarded, along with some other local institutions, an NCORE grant. Now, the NCORE stands for the NCI Community Oncology Research Program, and this is one of 47 programs around the country that is really focused on bringing first-rate research to the local community level. That has been spearheaded by one of our founders, Jay Bearden, and now is also run in part by two of my partners, Jeremy Kilburn and Amy Curtis. So they've done a tremendous job with that. As you heard in the video, there are a lot of services available at the new Cancer Center, including sort of the usual medical oncology, radiation oncology, surgical oncology, but also orthopedic oncology, gynecologic oncology, and a variety of other services. Some of those, unfortunately, are sidelined a little bit due to the COVID crisis that's ongoing, but we certainly expect as that gets under control, we'll get everything fully up and running. This gives you a little bit of a sense of the clinical trials work. This is actually a slide that just looks at the clinical trials accruals, or that is the patients who have enrolled on trials just in 2020 from January to September. So during that 9-month period, we've had over 600 patients enroll on clinical trials. This represents a very large fraction of our patients who we see. Now, in cancer centers in general, they try to enroll somewhere between 2 and 4% of their patients on clinical trials. The goal for most centers is 4%, and if you're exceeding that, then you're doing quite well. Just to give you a sense of how well we do with enrollment of patients on trials, this represents 28% of the patients that we have seen during the course of the year. In addition, we have 176 ongoing clinical trials. Now, one of the things that we also focus on, not just at the Gibbs Cancer Center, but at in Spartanburg Regional as a healthcare system in general, is making sure that we have the most advanced technology available so that our patients can get the best care possible. This ranges from things like being early adopters of this machine, a robot for doing a variety of surgeries. A lot of our prostate cancer patients, for example, have prostatectomies or prostate surgery using a robot like that, but it's used for a wide range of different surgeries now. We're early adopters of a lot of important imaging technology. Also, this is something called navigational bronchoscopy. This allows for patients with lung cancer to have a probe actually driven out through sort of from the inside down. It goes down the throat and out into the lung, and you can actually sample lung tumors and do other things from the inside rather than having to come from the outside. Now, one of the other things that we have had that is a real advancement in technology here is the CyberKnife. So the CyberKnife is basically a robotic arm with a miniaturized linear accelerator, which is basically a radiation producing machine mounted to it. And I'm going to show you in just a second a video that that you can see the CyberKnife in action. So here you see a patient lying on a treatment table. You can see the robotic arm and the machine attached to that. This is a patient getting moved into the middle of the room where the treatment takes place. Here you can see, again, the treatment taking place. It doesn't touch the patient, so completely non-invasive. and it can deliver very high doses of radiation with great precision. This is a lung cancer patient wearing a special vest, and we'll talk about that vest in a little more detail in just a minute. Here's a patient getting treated for a brain tumor. So again, just briefly, this is the robotic arm. Here is that miniaturized linear accelerator, and then the additional robot that is attached to the treatment table that positions the patient in the proper location to get that treatment. Here you can see it again. Now, you can see the patient wearing that vest as well. But if you think that this arm looks at all familiar, it is actually made by the same company, KUKA. It's a German company that makes the robotic arms for the BMW manufacturing plant just up the road from us. So the same robot that can pick up a car chassis and move it around is what we have, picking up a fancy linear accelerator and delivering radiation treatments. So one thing to bear in mind, it is called CyberKnife, but there is no knife, okay? I have a lot of patients who come to me and they say, oh gosh, I'm really worried about this knife. And I have to explain to them, no knife involved at all. What it is just focused radiation, completely non-invasive. Now, there are what this machine does is deliver very high doses of radiation in just a few treatments with great precision. And when we deliver these high doses of radiation at a single or in a short period of time like that, we refer to this as a few different things. It can be called stereotactic radiosurgery, SRS, stereotactic body radiotherapy, SBRT, or even stereotactic ablative radiation, which in Europe they call that SABR. It all means the same thing, though. These are basically very, very high doses of radiation delivered very quickly over just a very few treatment sessions. If you compare that to what we do with what we call conventional radiation, in that situation, we're giving just a little bit of radiation every day over a number of weeks. Here, what we're talking about is using only 1 to 5 treatments, typically given just over the course of anywhere from 1 to 5 days, or sometimes we do it on an every other day basis. So radiosurgery, the goals are a little bit different than they are for conventional radiation. Again, with conventional radiation, you're giving that little bit every day, and when you do that, you are treating a little bit more gently, and you can treat more normal tissue in that treatment area. And what that means is certain areas of the body where you can't avoid that normal tissue, you really don't want to use this very focused high dose radiation, but there are a lot of places where this works great. And again, allows us, here it says minimally invasive, but actually think of this as actually being non-invasive, completely non-invasive, focused radiation with high precision, and it's very, very biologically potent, meaning that it has a very high probability of killing the cancer. Now, there are lots of different sites that we can treat with the CyberKnife. There are primary cancers that we treat. The most common ones of those would be prostate and lung, but we can also treat what's called metastatic sites, that is places where a cancer has spread. So it may have started in the lung, but it could have spread to the brain or something like that, and we can treat these areas with the CyberKnife as well. In fact, the two most common areas that we treat with the CyberKnife as far as metastatic sites would be brain by far, but then also the spine. We can also treat benign conditions or non-cancerous conditions with the CyberKnife. Typically, when we do that, we're treating areas that are inside of the head, in areas that are very difficult to operate on. And so we can treat with that very focused radiation, and it's highly effective at getting rid of those benign, either benign tumors or sometimes treating conditions that cause pain or other things, and it can alleviate that pain. Here you can see in our experience what we have been doing with our CyberKnife. We've treated over 1,150 patients with the CyberKnife. Over half of those have treated either the brain or things within the skull. That is, some of those benign conditions are contained within that. But about half of the patients that we treat have gotten treated for things in or around the brain. A little over a third of patients have been treated for prostate cancer, and about 10% for lung cancer, and then a variety of other types of cancers or benign conditions. Now, November's Lung Cancer Awareness Month, so we're going to talk a little bit first about lung cancer. Now, lung cancer for both men and women is the second most common cancer diagnosed. So well over 200,000 lung cancer diagnoses in this country every year. And these are statistics from the American Cancer Society for 2020. And you can see, even though they're the second most common cancers, they're actually the leading cause of cancer death in men and women in this country. So lung cancer, by far the most common cause of cancer death in the United States. Now, I was telling you a little earlier about this vest. So this is a vest that has special tracking markers on it. And this allows us to actually track where a lung cancer tumor is in real time. So as a patient breathes, there's actually motion taking place of that lung cancer. If you were to use a conventional treatment machine, you would just have to build in bigger margins to account for where that tumor might be as the patient breathed. But with the CyberKnife, you can actually track in real time where that is and keep your margins much tighter and spare more normal lungs. So here's a patient who is wearing that special vest, and you can see this camera here is getting signals from the vest, and it allows us to see the respiratory motion, and it then will tell the CyberKnife, the treatment machine itself, exactly how to follow that tumor. So here it is, just telling you a little bit about it. So again, it tracks the tumor throughout the breathing cycle so that you can continuously deliver radiation as the patient just lies there breathing freely. It permits us to tighten our margins and reduce the amount of normal lung, which is very, very important for a lot of these patients who come to us with quite poor lung function to begin with. Changing gears a little bit, let's talk about prostate cancer. So prostate cancer is, as I was just saying, the most commonly diagnosed cancer in men in this country, with nearly 200,000 men diagnosed every year. And there are lots of different ways to deal with a prostate cancer. In fact, the most common way that prostate cancers are dealt with in this country is actually with something called active surveillance. That is, at least half of cancer patients, or prostate cancer patients, don't actually need any intervention. They don't need to be treated for their cancer because some prostate cancers are very, very slow growing, and typically they're diagnosed in elderly patients. And so you can just monitor those over a long period of time, and most of those patients don't wind up actually needing treatment for their cancer. On the other hand, as I was saying before, prostate cancer is the second leading cause of cancer death in men in this country. So you can't just say, oh, it's just prostate cancer, don't worry about it. You first have to differentiate which ones are really dangerous from which ones aren't. And once you decide that one is actually dangerous enough that it needs to be treated, there are a variety of different ways of doing that. So the most common way that we do that treatment would be surgery. But surgery is usually reserved for younger men, typically age 70 or younger. And the reason for that is that as men get older, they don't tolerate the surgery as well, and they have a lot more side effects associated with it, particularly things like urinary leakage and incontinence. Radiation, on the other hand, is the next most common type of treatment for prostate cancer, but there are no real age limitations for that, and there's a variety of different ways that this can be done. We'll talk a little bit more about that in just a minute. A couple of other things that I'll just mention briefly. You can use cryotherapy, which is freezing the prostate, or you can use sort of the opposite of that, something called HIFU, high intensity focused ultrasound, which is heating the prostate. So there are lots of different ways of treating prostate cancer. We're going to focus just for a moment on some facts about prostate cancer, and then shift our talk to discuss radiation in the treatment of prostate cancer. So first of all, prostate cancer is very, very common, as I've been saying. 1 out of 7 men in this country during his lifetime will be diagnosed with prostate cancer. The average age at diagnosis is 66. Now, even though 1 out of 7 men will be diagnosed with prostate cancer, only 1 out of 39 men actually dies of prostate cancer in the United States. And that speaks to the fact that a lot of these are not very aggressive, and also that we've developed good ways of treating men who have prostate cancer. But this fact, the fact that we have a lot of men who have the disease who don't die from it, tells us there are a lot of men in this country living with prostate cancer. In fact, nearly 3 million of them. So let's talk a little bit about radiation therapy for prostate cancer. And now, first of all, this right here is a picture of what we call a conventional linear accelerator. That's a conventional treatment machine, to be contrasted a little bit with the CyberKnife that we've been looking at, which is kind of a more highly specialized machine. Radiation therapy for prostate cancer is very versatile. That is, we can treat patients with low risk disease all the way to very high risk disease. With some of these approaches, we shy away from the use of certain approaches depending on how high or low risk the disease is. There are no prostate size limitations. That is to say, that it doesn't matter how big or small the prostate is, there's always a radiation option that will work. There are also no age limitations. That is, unlike surgery, where we don't like to treat the more elderly patients because of potential side effects, there is not a big difference in the side effects that men experience, whether they're 60 years of age or whether they're 80 years of age. So, so we are, in that regard, very versatile. This radiation is the least invasive way of treating prostate cancer. In fact, other than the placement of some tracking markers into the prostate, it really is a non-invasive procedure entirely. It also results in excellent prostate cancer disease control, meaning it does a very good job of curing patients of prostate cancer. In fact, from the data out there, probably better than the freezing or the heating of the prostate, and very comparable to surgery. And in fact, for high-risk patients, there's some data suggesting it may even be better than surgery. The goals of treatment, basically to treat the prostate to a really high dose while avoiding damaging the normal surrounding structures. Now, with a conventional approach to treatment, we typically are going to treat in anywhere from about 28 to 45 treatment sessions. When we use the CyberKnife, on the other hand, we typically use 5 treatment sessions. So that is one big difference between conventional treatment approach and the CyberKnife. Now, one of the most important things to know about prostate cancer is that the potential side effects of treatment have to do with location. That is, it's in a very sensitive area, and we can see here, this is the prostate, and it is right in the middle of the pelvis. Just above it is the bladder. Just behind it is the rectum. The nerves that control erectile function run right alongside of it. And the area at the root of the penis called the penile bulb, the bulb that controls blood flow for erectile function, is just below it. So there is a lot of potential for there to be damage to normal function for a man being treated for prostate cancer. And that's true whether you're talking about a surgical approach, whether you're talking about a radiation-based approach, or any other approach to the management. Now, in the world of radiation, one of the thing that we historically have worried about the most is this front wall of the rectum right here. Now, this area in normal anatomy is located literally just 1 or 2 millimeters behind the prostate. There's just a little fat plane that separates the two. And when we treat with radiation for prostate cancer, we always treat with a margin around the prostate to account for motion, to account for the possibility that there could be microscopic disease that extends through the capsule of the prostate and into the tissue just surrounding it. And because we build that margin in, historically we had built that margin right into the front wall of the rectum. And long term, that could result in something called radiation proctitis. Now, radiation proctitis means that there's an inflammation in the area of the rectum caused by radiation. And the result of that can be things like irritative symptoms in the short term, but in the long term, things like bleeding from the rectum or even damage to that rectal wall that's severe enough that it requires an operation to fix it. So one of the things that has been developed recently to try to combat that is something called SpaceOAR. Now, I mentioned this a little bit earlier. SpaceOAR is something that we've been doing since 2015 at the Gibbs Cancer Center. Now, this is something that has gained much greater popularity and use over the last year or so, but we were fortunate enough to be very early adopters of this technology, and it's been a great benefit to our patients. This is a gel that is placed into the space between the prostate and the rectum. So this picture shows you a cross section. This is the prostate, and this red area around it is that margin that we have to build around the prostate. And then just behind that, we see the rectum. And here you can see that margin having been built right into the front part of the rectum. This picture shows you SpaceOAR, and SpaceOAR has been placed into that space and just physically pushes the rectal wall backwards and away from the prostate. And then we can build in this margin around the prostate and not build it into the front wall of the rectum. And so long term, what we see is a great reduction in the significant injury to the rectal wall. Now, this gel has been formulated to stay stable and in place for about 3 months, and it just slowly dissolves, it liquefies, and it's eliminated as urine. So, patients don't have to have anything done to remove it. And in fact, the placement of it takes only the placement of an 18 gauge needle into that space. So there are no scalpels or stitches. It's a very quick, easy procedure with very, very low risk associated with it. Now, shifting gears again, let's talk a little bit about treatment of brain tumors and other things in and around the brain with CyberKnife. So we can treat things like primary brain tumors, that is cancers that start in or right near the brain. We can treat metastases. Again, these are things that would have spread from another cancer. And in fact, it used to be that we only treated a single brain metastasis. So if somebody had just one spot that had spread to the brain, we would treat that. But that way of managing brain metastases has changed quite dramatically to the point where we now treat as many as 20 or more brain metastases in a single treatment session using the CyberKnife. We also, again, can treat those non-cancerous conditions like meningiomas. These are things that arise from the covering of the brain, or trigeminal neuralgia. This is a painful condition affecting the face that is the result of irritation of a nerve that comes out of the brain called the trigeminal nerve and goes to kind of all across the face, or something called acoustic neuroma, which is affects another one of the cranial nerves that again comes out of the brain, and this one goes over to the inner workings of the ear. All of these can be treated very, very nicely with the CyberKnife. Now, there are other ways of treating with radiation very precisely to things inside of the head. One of those things is called a gamma knife, and in fact, the name CyberKnife was sort of as a play on the gamma knife. The gamma knife has been around since the 1950s, but one of the downsides of the gamma knife is that it has historically required a head frame to be placed. This is a metal frame that actually gets bolted to the skull in order to immobilize the patient for doing the treatment. So as you might imagine, that can be a little bit uncomfortable. This is an immobilization mask that's used with CyberKnife. This is a mask that starts as a flexible mesh. It turns into a rigid plastic that you can see through and breathe through, and it does fit quite snugly. And it is very good at immobilizing a patient so that the position that we do their planning in is the same position then that we use for doing each of their treatments. Just to summarize briefly, so if we think about conventional radiation, again, that's the type of radiation where you give a little bit of radiation each day over a number of weeks, compared to what we do with CyberKnife, which is to treat just a very few treatments with much higher doses of radiation per treatment. If we look at the brain, typically we're going to do that in 10 to 15 treatments with conventional approach, whereas we often will do that in a single treatment using the CyberKnife. If we're going to treat the lung, we may treat as many as 35 treatments conventionally, but with the CyberKnife, again, typically that's going to be done in 1 to 5 treatments, most commonly in a 3-treatment regimen. If we're treating the prostate, we might treat as many as 45 treatments in a conventional approach. Again, with CyberKnife, only 5 treatments for that. And finally, if we're going to treat something like a liver tumor, which might be a metastasis, something that has spread to the liver from somewhere else, or it might be a primary liver tumor like a hepatocellular carcinoma, these would typically be treated in 10 to 30 treatments, but with the CyberKnife approach, 3 to 5 treatments is more typical. And keep in mind that we have about a 90% local control rate for these, meaning that about 90% of the time we can get rid of the cancer in the spot that we treat. If you compare that to conventional treatment, it's significantly better. That would be more like 60 to 70%. So it's quicker, more convenient, but also more effective in many situations than treating with a conventional approach. Now, if you or someone you know is interested in finding out whether the CyberKnife or some other technology that we have at the Gibbs Cancer Center may be appropriate for you, you can contact us through our second opinion clinic. This allows a formalized second opinion where you would be evaluated by a team of specialists and other medical professionals, and we would review and evaluate your treatment plan and give you an opinion on what we would do if you were to be treated at the Gibbs Cancer Center. Patients who come in for a second opinion will have access to all those clinical trials that we discussed and the cutting edge technology that we've just talked about as well. We have a multitude of cancer specialists, and we are always focused on individualizing the care that is most appropriate for our patients. If you're interested in getting a second opinion, you can reach us either online at spartanburgregional.com or you can call us at 1-855-DNA-GIBBS. That ends the formal part of the presentation. I'm happy to answer any questions for you that you might have.
Okay, Dr. Freed, we do have a few questions. Yeah. So the first question is, if I do need a second opinion, do I come in person to Gibbs Cancer Center, or is my information sent over and reviewed, and then the opinion is given to me by phone or by video? How does the second opinion clinic work?
So there's a variety of ways that we could do this, but the general idea is this, that you would get all of your records over to us, and we will facilitate that by, getting them from your doctors that have given you the original opinion. It would be reviewed by our team of experts, and that within 48 hours, we would have an appointment for you so that you could be seen in person for that. Now, if for some reason you were unable to have an in-person visit, we have the technology to do telemedicine visits and so forth. But I think I think it's better in general to have those as in-person visits when possible.
Great. So even if I have family members that are out of state and they want to get a second opinion, they can still use the second opinion clinic the same way as someone in state could use it?
Absolutely. I have patients that come from as far away as Texas, New Jersey, Florida. So we have a number of patients, especially who are coming for the CyberKnife because it's a technology that's not available everywhere. But the reality is we have a great team of experts that are knowledgeable about essentially all cancers. And so we do welcome people from outside of our immediate geographic area.
That's quite a great service. So that's good to know. Thank you for that. The next question is, if I'm enrolled in a clinical trial, where are the clinical trials performed?
So, we have these clinical trials available right here. Now, many of these are national trials, meaning they're available at lots of different centers across the country and sometimes even around the world. And others are more specific to what we have going on here at the Gibbs Cancer Center. But the idea would be that you would get your care here, that those clinical trials are available right here. And when people come in for that second opinion, or when we see them just in, as a matter of getting a first opinion, we are always thinking about what clinical trials might be available to them, because often this allows them the most cutting edge approach to treatment of their disease.
Okay, thank you. The next few questions are on CyberKnife. Can you treat all cancers with CyberKnife? And if not, why not?
So the short answer is you cannot treat all cancers with CyberKnife because CyberKnife treats small things anywhere in the body to very high doses over just a few treatments. Now, what that requires is, for example, a very definable target. So if you have something where you can't see the thing very well, then CyberKnife is likely not going to be the appropriate way to approach that. That is, so for our prostate cancer patients, for example, when we're treating primarily with, so that is with the prostate still there, then we use CyberKnife for that very frequently. But if the prostate has been removed and there's no longer a really definable target, but we want to treat that area post-surgically to try to get rid of microscopic disease that may exist there, we have to use that more conventional approach to do that, where you're just treating a little bit each day, because mostly what's in the treatment area is normal tissue rather than just, say, the prostate and the cancer within the prostate. Other things we can treat in certain situations. For example, for a small lung cancer, we use the CyberKnife for it. But if it's a big lung cancer with a lot of lymph nodes, for example, in the middle of the chest that have been involved, that again, we're treating a great big area then, and with a lot of just regions that need to be treated more gently. And in that situation, again, we need to treat with a conventional machine rather than with the CyberKnife. And so it isn't so much that there are cancers that we don't treat with CyberKnife, but there are specific situations for each cancer that we don't.
Okay, that sounds good. Are all patients that are getting the CyberKnife treatment, are they sedated or are they awake?
So that's a great question. The CyberKnife doesn't require any sort of sedation, and in fact, patients can't even feel it when they are treated. Okay, so they are literally just lying on a treatment table without being in a device. The only time we immobilize anything, and in fact, is when we use that the mask that I showed you for treating things inside of the head. For everything else, the patient is just lying comfortably on the treatment table. In fact, it's on a memory foam pad, so it's really not even an uncomfortable table to be lying on. And the machine will basically compensate for any change in their position. We're continuously also re-imaging their position to make sure that there's no movement, but the fine-tuning adjustment is taking place within the machine itself.
Good, well, thank you. And how long does the normal CyberKnife treatment session last?
Typically anywhere from about 20 minutes to an hour, just depending on the disease site and how many treatments are being delivered and what the dose is that is being delivered. So a lot of factors kind of play into that, but for the vast majority of treatments, it will be less than an hour.
Okay, well, thank you on that. The next question is, if I have prostate cancer and I'm treated by CyberKnife, when will I know if it's been successful, and how is success rate determined?
Right, that's actually kind of a tough question to answer. Let me just contrast that with surgery. So with surgery, you know you've been successful very quickly. That is to say, when you remove the prostate, you have removed everything from the body that should be capable of making PSA, which is the blood, the protein in the blood that we measure to tell us about whether there's prostate cancer or not. Okay, so if you remove the prostate and you wait for about a month or 6 weeks, then all of the PSA that was in the bloodstream should have been cleared by then. And when you do that blood test, you should find an undetectable PSA. With radiation therapy, on the other hand, it's a much more gradual process. That is to say, when we treat with radiation, it doesn't immediately kill the cancer, and it doesn't remove the prostate. So what we find is that we have a gradual decline in the PSA over a long period of time. I have patients where their PSA has been declining for 3 or even 4 years. And typically, when it does plateau at a very low level, it will still be detectable. So maybe in the range of 0.1 to 0.3, something like that would be kind of a typical place for it to land once it's all done. Now, in terms of knowing whether you're disease-free, again, it's kind of a longer process, though you get a much better sense of it as you follow things over time. And typically, we follow these PSA levels at 3-month intervals over a long period of time. We watch that PSA come down, and as long as it's behaving properly, typically we'll find that patients long-term have been cured of their disease. So for a low-risk prostate cancer, our typical cure rates for CyberKnife are about 95%. For an intermediate risk patient, it may be more in the kind of 80 to 85% range. But if you look at this compared to surgery, it's very comparable to the long-term disease control rates that we see for surgery.
And with the CyberKnife treatment, do you see less erectile dysfunction or urinary leakage than you do with traditional surgery?
So this is especially true as patients get older. So for young patients do great with surgery. They bounce back quickly. So if you're talking about a 55-year-old patient or something like that, then in general, we try to steer them towards surgery because we feel like they're going to do great with surgery. When you're talking about men as they get to age 70 and beyond, they start to run quite a high risk with surgery of having urinary leakage and incontinence. If you look at the rate of urinary leakage and incontinence for those patients treated with CyberKnife versus surgery once they're at age 70 and beyond, it is dramatically lower for radiation than it is for surgery. As far as erectile dysfunction goes, there is a slight difference between them. Any treatment that you use for prostate cancer has a significant risk of inducing erectile dysfunction. Now, the mechanism by which that happens is a little bit different for surgery versus radiation. Typically with surgery, we're talking about a nerve problem, that the nerves that I showed you before, where the nerves are running alongside the prostate, these have to be delicately removed from the sides of the prostate in order to remove the prostate in a prostatectomy. And invariably, there is some damage to those nerves. The amount of damage depends on the skill of the surgeon. It depends on how well the patient heals, and often on the age of the patient. Also, it depends on how the function is going into the operation. With radiation, a little bit less risk of erectile dysfunction than there is with surgery, but it's not an absolute given that men who get treated with radiation will preserve their erectile function.
Okay. And then the last CyberKnife question is, we realize that we're blessed to have this wonderful CyberKnife at Gibbs. Where is the closest comparable CyberKnife located?
So in the state of South Carolina, there is only one other CyberKnife, and that's down in Charleston. It's a much older machine and doesn't have some of the same capability that our CyberKnife has. There is a fairly comparable machine that has just been put in up in Asheville. And aside from that, there's not one very close to us. You would need to go to Atlanta to get to the next one.
Okay, thank you for that. And on to a different topic. With cancer patients, are they at an increased risk for COVID infection?
Well, it depends on the situation, okay? So especially for patients who are undergoing chemotherapy, they may have decreased white blood count that, where their immune system may be not working quite as well. And they are more susceptible, not just to COVID, but to every opportunistic infection that's around. On the other hand, if we're talking about radiation patients, radiation can lower that white blood count according to how much bone marrow is in the area being treated. So if we're treating great big areas, there may be a small impact on the white blood cell count. If we're talking about something like a CyberKnife treatment for prostate cancer, there's essentially no change in their immune function. So really kind of is case specific. And so for a lot of our patients who are undergoing treatment, this is a discussion that we have with them because certainly this is the thing other than their cancer that's first and foremost in their thinking. Having said that, everybody needs to be careful about COVID, okay? It doesn't matter whether you're a cancer patient or not. It doesn't matter whether you're old or young. This is a disease that is very highly contagious, and so that even for young people who are maybe asymptomatic, they can still spread it to people who can become very, very sick from it and even die from it. So again, we have to be very careful. I can't stress enough how much we should be wearing masks, washing hands, exercising, social distancing, and just being very careful about this. Hopefully the vaccines that are under development will be disseminated soon and we'll all be in much better shape at that point. But until then, we just have to be very careful.
Okay, thank you for that. And as our last question, with your expertise in both research and cancer treatment, are you optimistic about the future? Do you see a lot of good things coming, or do you think it's just going to kind of be status quo for a while?
Oh, there are so many great things in development right now in the world of cancer research. Yeah, we're making great strides. Partly in the world of radiation oncology, we're making some, but, in the world of medical oncology, I think tremendous advancements in targeted therapies, immunotherapies. These are things that I think are the future of cancer care. Even as a radiation oncologist, I'm willing to admit that some of the things that are on the horizon for our medical oncology colleagues to have at their disposal are going to be really game changers. So I'm very optimistic about where we are going to be over the next several years.
Okay. Well, Dr. Freed, thank you so much for your time and your expertise today. We're glad you're a part of our system, and we appreciate all you do for this community and for the cancer patients that you treat. Thank you so much for your time.
Thank you so much for having me. I really appreciate it.